Hi, I'm Dr. Chris Lewis, one of the chief educators here at Doctors in Training. I want to welcome you once again to another solid anatomy lecture, and this one's on the face and the scalp. In this video, we'll be covering the muscles of facial expression. Also in this lecture, we'll discuss cutaneous innervation and blood supply to the face as well. Now, I'll be back later for a clinical correlation and for the end of session quiz. But for now, I'm going to turn it over to our primary lecturer, Dr. John Phelan.
A popular way to define the face is to say that it is the portion of the head that is provided with cutaneous innervation by the trigeminal nerve. That's partially true, as nearly all of the skin of the face is indeed innervated by the trigeminal nerve. But the anterior portion of the scalp is provided with cutaneous innervation by the trigeminal nerve as well. The remainder of the scalp, along with the neck, receives cutaneous innervation via dorsal and ventral rami of cervical spinal nerves. In this solid anatomy lecture on the face and the scalp, we'll investigate such pertinent topics as cutaneous innervation, muscles of facial expression, and blood supply. If we look at a map of the cutaneous innervation of the head, we see that the face is divided into three regions, each representing the territory of a division of the trigeminal nerve. Since the trigeminal nerve is the fifth cranial nerve, it is represented by the letter V, which is also the Roman numeral 5. V1 is the first division of the trigeminal nerve, or the ophthalmic division. V2 is the maxillary division, and V3 is the mandibular division. The cell bodies of the pseudo-unipolar neurons that are sensory to the skin of the face are found in the trigeminal nucleus in the middle cranial fossa. Their central processes enter the pons and synapse in the three sensory trigeminal nuclei in the pons and the medulla, which are, from rostral to caudal, the mesencephalic nucleus, the pontine or primary nucleus, and the spinal nucleus. The peripheral processes of these neurons run in the ophthalmic, maxillary, or mandibular divisions of the trigeminal nerve. The ophthalmic division passes through the superior orbital fissure, enters the orbit, and divides, or some might say trifurcates, into a nasociliary nerve medially, a frontal nerve centrally, and a lacrimal nerve laterally. The lacrimal nerve leaves the orbit and innervates skin on the lateral part of the upper eyelid and surrounding portions of the face and forehead. The frontal nerve bifurcates into a supraorbital nerve and a supratrochlear nerve. The supraorbital nerve enters the face through the supraorbital notch, or foramen. Some orbits have a notch and others have a foramen, on the superior margin of the orbit. It innervates skin over the middle part of the superior eyelid and across the forehead and anterior scalp. The supratrochlear nerve passes superior to the trochlea, which is the fibrous pulley for the superior oblique muscle of the eyeball found on the medial aspect of the superior orbital margin, and innervates skin on the medial part of the superior eyelid and superiorly on the forehead. The nasociliary nerve gives off an infratrochlear branch that passes inferior to the trochlea on its way out of the orbit. The infratrochlear nerve innervates skin on the superior part of the nose. Another branch of the nasociliary nerve, the anterior ethmoidal nerve, ultimately leaves the nasal cavity after innervating mucosa and exits the nose to innervate some of the skin covering it. The maxillary division of the trigeminal nerve gives off the infraorbital nerve that enters the orbit through the inferior orbital fissure, runs along the floor of the orbit in the infraorbital groove and canal, and exits out onto the face through the infraorbital foramen, just inferior to the inferior margin of the orbit, deep to the levator labii superioris muscle. Branches of this nerve innervate skin on the inferior eyelid, the inferior portion of the nose, the cheek, and the superior lip. The zygomatic nerve, another branch of V2, enters the orbit and divides into a zygomaticotemporal and a zygomaticofacial nerve that pass through canals that lead them to the surface of the zygomatic bone. Here, these nerves innervate skin over the cheek. The mandibular division of the trigeminal nerve gives off the auriculotemporal, buccal, and inferior alveolar nerves in the infratemporal fossa, an area that will be detailed in the solid anatomy lecture on the deep face. The auriculotemporal nerve passes posterior-superiorly and emerges anterior to the auricle. It innervates some skin on the auricle and the temporal region. The inferior alveolar nerve passes through the mandibular foramen on the medial side of the ramus of the mandible, passes through the mandibular canal where it gives off sensory branches to the mandibular tooth sockets, and emerges onto the face via the mental foramen as the mental nerve. The mental nerve innervates skin over the chin and lower lip. The buccal nerve, or long buccal nerve, passes inferomedially and gets out of the face by passing between the masseter and the buccinator muscle. It sends some branches to the skin over the buccinator muscle and sends some branches through the buccinator muscle to innervate oral mucosa, but it is not the motor nerve to the buccinator muscle. The remainder of the skin on the scalp is innervated by two branches of the cervical plexus, the great auricular nerve and the lesser occipital nerve, as well as the dorsal ramus of C2, which is called the greater occipital nerve, and the dorsal ramus of C3, which, like the remaining dorsal rami, does not have a name. You'll recall that the skull, or cranium, may be divided into a neurocranium, composed of the bones surrounding the brain, and a viscerocranium, which are the 9 bones of the face. These bones are the mandible, the maxilla, the vomer, the zygomatic bones, the temporal bones, the palatine bone, the lacrimal bones, the ethmoid bones, and the sphenoid bone. The skeletal muscles that insert on the skin, or more specifically, the dermis, which is the connective tissue layer of the skin deep to the outer epithelial epidermis, are the muscles of facial expression. They take their origin from the bones of the viscerocranium, or in some cases from fascia, and act to move the skin of the face to communicate emotions, signals, and thoughts. The occipitofrontalis muscle consists of a central aponeurotic sheet that forms the middle layer of the scalp, with one muscle belly extending from it anteriorly, the frontalis, and one extending from it posteriorly, the occipitalis. The frontalis muscle elevates the eyebrows to indicate surprise and forms horizontal wrinkles in the skin of the forehead, perhaps as an indication of disbelief. The occipitalis also forms wrinkles in the skin posteriorly that may be hidden by hair, and it assists the frontal belly by retracting the scalp. The orbicularis oculi muscle is very important for maintaining the health of the eyeball because it is the only muscle that can close the eye. It originates from the bones forming the orbital margin and from the medial palpebral ligament, and inserts on the tarsal plates at the core of the eyelids. The corrugator supercilii originates on the superciliary arches and inserts on the skin of the medial margins of the eyebrows. It draws the eyebrows together to create vertical wrinkles in the skin above the nose, indicating concern or worry. The levator labii superioris originates on the maxilla inferior to the orbital margin and inserts on the skin of the upper lip. It elevates the upper lip. You may recall the term modiolus from the solid anatomy lecture on the ear. It was the name given to the bony core of the cochlea. It is a Latin word meaning hub. In facial anatomy, the modiolus is the tendinous site of insertion of several muscles of facial expression found at each labial commissure. The levator anguli oris originates at the maxilla inferior to the orbital margin and inserts on the modiolus. It elevates the labial commissure bilaterally to smile and unilaterally to sneer. The origin of the risorius muscle varies. Common sites are the zygomatic arch, the fascia surrounding the parotid gland, and the buccal skin. It inserts on the medialis and opens the mouth, or we could say it widens the rima oris. The kissing muscle, the orbicularis oris, originates at the modialis and the maxilla and mandible at the level of the second incisor. The right and left side of this muscle cross each other at the midline and insert into the skin. This muscle allows you to manipulate your lips. You can pucker them, press them together, and turn them inward. The muscle of the cheek is the buccinator, which is named for the Latin word for trumpeter because it resists deformation due to blowing actions as well as sucking actions. It shares its origin with the superior pharyngeal constrictor muscle at the pterygomandibular raphe. It inserts on the medialis. The muscle tenses during chewing to keep food between the teeth rather than collecting in the cheeks lateral to the gums. Remember, however, that they are not muscles of mastication. They are muscles of facial expression. They can also contract to help blow air out of the mouth. The zygomaticus major and minor originate near each other at the zygomatic bone. The major inserts at the medialis and the minor inserts on the upper lip. The major draws the angle of the mouth superolaterally and the minor elevates the upper lip. Activate them unilaterally and you'll sneer. Bilaterally and you'll sort of smile. The depressor anguli oris is a frowning muscle. It originates on the anterolateral base of the mandible and inserts on the medialis. It depresses the labial commissures. The depressor labii inferioris helps indicate sadness and disappointment. It originates from the lateral part of the body of the mandible and inserts on the skin of the lower lip. It can both depress and evert the lower lip in a pouting manner. The mentalis originates on the body of the mandible anterior to the roots of the inferior incisors and inserts on the skin of the chin. You may use your mentalis to protrude your lower lip and wrinkle the skin over your chin. The procerus originates on the lateral surface of the nasal bone and the superior portion of the lateral nasal cartilage and inserts on the skin between the eyebrows. It wrinkles the skin on the nose to convey dislike. The nasalis muscle has an alar portion and a transverse portion that both originate on the maxilla. The left and right transverse portions meet in a central aponeurosis over the nasal bone and compress the alar cartilages to close the nostrils, while the alar portions insert on the alar cartilage and pull them laterally to flare the nostrils. The platysma is a thin sheet of muscle in the superficial fascia of the neck that attaches superiorly along the anterior surface of the body of the mandible and inferiorly on the fascia surrounding the clavicles. It creates prominent wrinkles in the skin of the neck, indicating an at times comical degree of stress. It also blends in with facial muscles surrounding the mouth to depress the lower lip and the angles of the mouth. It may also assist in depressing the mandible and elevating the ribs and sternum during forced inspiration. All of the muscles of facial expression are innervated by the seventh cranial nerve, the facial nerve. Facial nerve motor neurons arise from the facial nerve nucleus in the pons. The facial nerve exits the neurocranium via the internal acoustic meatus, which leads to the rather complicated facial canal in the temporal bone. The nerve exits the facial canal through the stylomastoid foramen and runs into the substance of the parotid gland anteriorly. Within the gland, the facial nerve branches into what most anatomy textbooks describe as 5 divisions. In order from superior to inferior, these are the temporal, zygomatic, buccal, mandibular, and cervical divisions. Cadaveric studies have shown that while this is the most frequently observed facial nerve branching pattern, it is found in less than 25% of the population. So be prepared to see tremendous variation when it comes to the motor branches of the facial nerve.
Okay, welcome back, and now we're going to go through the clinical correlation. Now today I want to briefly go over Bell's palsy. Now this is a unilateral facial paralysis from dysfunction of cranial nerve 7, also known as the facial nerve, so that's easy to remember. This can occur with inflammation of the facial nerve near the stylomastoid foramen. Now this will actually compress the nerve in this area. Now it generally presents very suddenly and progresses over the span of hours. Patients will have eyebrow sagging, the inability to close the eye, disappearance of the nasolabial fold, and the mouth will be drawn to the non-affected side as well. So how would you be able to distinguish this from a stroke or a brain tumor or something else neurologically going on? These can all pretty much present with a facial droop. Well, Bell's palsy is a peripheral neuropathy, which will affect the muscles of the forehead. Now, the forehead muscles actually receive innervations from both sides of the brain. So if the problem is central, like in a stroke, then you actually won't see any problems with the muscles of the forehead. The rest of it will look very similar, but that forehead will be spared in a stroke. If a patient is unable to raise their eyebrows, then always think of Bell's palsy. I try to remember that Bell's palsy oftentimes looks a lot worse than a stroke in the face, even though a stroke is usually a lot worse prognosis. So far in medicine, we actually don't know what causes Bell's palsy. Now, one hypothesis is that herpes simplex 1, because this has been identified in multiple cases. Also, herpes zoster is another possible cause. So if you have Bell's palsy, what are the likely outcomes? If you have an incomplete facial palsy, it's really not all that bad, then more than likely you're going to have a complete recovery. Treatment usually is even unnecessary at that point. If a patient has a severe palsy, a severe Bell's palsy, then you're going to use things like oral glucocorticoids. They can be used and should be started usually within the first 3 days of symptom onset. And usually this, since I said before that this was such a rapid onset, people are coming in because they're freaked out or they think they're having a stroke. So most of the time you can get these medicines in relatively quickly. And because it's thought that Bell's palsy is due to either HSV or herpes zoster, then many would also recommend using an antiviral like valacyclovir in severe cases as well. Eye care is also very important to remember. Patients can't close their eyes. If their eyes are staying open while they're sleeping, then they can dry out their eyes, so you always want to protect the eyes, either tape them shut, also use some lubrication as well. Okay, so that's enough lecturing from me. Let's go over these questions. First one, what nerve is involved in Bell's palsy? So that should be easy. Remember, this is cranial nerve 7, the facial nerve. Next, what is the usual location of the nerve impingement in Bell's palsy? Remember, this is the stylomastoid foramen. All right, so let's get back to that lecture.
The arteries of the face arise from branches of the internal and external carotid arteries. The internal carotid artery gives off the ophthalmic artery that runs through the orbit and exits onto the face. The external carotid artery gives off the facial artery that crosses the inferior border of the mandible to reach the face. The external carotid bifurcates lateral to the ramus of the mandible into the superficial temporal artery and the maxillary artery. The superficial temporal artery gives off the transverse facial artery. The maxillary artery enters the deep face and gives off an inferior alveolar branch and more distally an infraorbital branch. The infraorbital artery exits the infraorbital foramen to reach the face, while the inferior alveolar artery passes through the inferior alveolar canal in the ramus of the mandible and emerges on the face through the mental foramen as the mental artery. All of these arteries anastomose with each other and supply the face. Venous drainage of the face mostly follows the arterial supply. Venous patterns are highly variable, and any statements made here are simply possible routes the veins of the face may follow. Superficial veins mostly follow superficial drainage patterns. For instance, the superficial temporal vein often joins the maxillary vein to form the retromandibular vein, which often joins the posterior auricular vein to form the external jugular vein. However, the veins of the face lack valves and are able to drain into deep venous channels as well. For instance, blood from the facial vein may drain into the deep facial vein, which leads to the pterygoid venous plexus in the infratemporal fossa, which is the space medial to the ramus of the mandible. Also, the facial vein anastomoses with the supraorbital vein, which may drain posteriorly through the orbit into the superior orbital vein, which drains into the cavernous sinus. An infection in the skin of the face may therefore potentially spread into the cranium. The letters in the word scalp serve as a mnemonic to assist in remembering the layers of the scalp. S is skin. C is connective tissue. A is aponeurosis, specifically the Galea aponeurotica that gives rise to the frontalis and occipitalis muscles. L is the loose areolar tissue, which allows the scalp to be physically shifted around with respect to the skull. P stands for periosteum or pericranium. The major blood vessels of the scalp run through the dense connective tissue of the second layer. These arteries are firmly attached to the connective tissue, which holds their lumens open when they're cut, which explains why scalp wounds bleed so profusely. The anastomotic arterial network of the scalp is contributed to by the superficial temporal arteries, the occipital arteries, the posterior auricular arteries, and the supraorbital and supratrochlear arteries. Venous drainage of the scalp is through veins that follow the arterial supply and are named identically.
So that covers the face and scalp. Now I want you to pause the video and answer the end of session quiz questions. Now there's going to be some questions covered that were not discussed in the lecture, but just do your best and then we'll go over those answers together. All right, let's get going. First question, what are the three main veins that drain the face and the forehead? So we have the facial vein, the retromandibular vein, and the superficial temporal vein. Next, what are the major branches of the maxillary artery? So we have the middle meningeal artery, the inferior alveolar artery, deep temporal arteries, and the superior alveolar arteries. Next, which nerve supplies sensory innervation to the face? That's going to be trigeminal nerve. Next, what are the divisions of the trigeminal nerve, and from which parts of the face do they receive information? So one part is the ophthalmic, and that's going to be tip of the nose to the top of the head. The maxillary part is the below the eyes to the upper lip. And then on mandibular, we have the lower lip to chin and the cheek. Next, which facial muscle performs the following action? So first we have closes eyelids, that's going to be the orbicularis oculi. Closes lips, that's going to be orbicularis oris. Elevates lips and dilates nares, that's going to be levator labii superioris. Draws angle of mouth backward and upward, that's going to be the zygomaticus major. Depresses the angle of the mouth, that's going to be depressor anguli oris. Elevates upper lip, that's going to be the levator labii superioris. Depresses lower lip, that's going to be the depressor labii inferioris. Elevates and protrudes lower lip, that's going to be the mentalis. Next, elevates eyebrows, wrinkles the forehead, that's going to be the frontalis. Next question. Which nerve supplies the sensory innervation over the following areas? So we have the angle of the mandible and bottom half of the ear auricle. So this nerve was briefly discussed in the lecture, but it's important to know that sensory innervation of the angle of the mandible and the bottom half of the auricle comes from the great auricular nerve. Now what about the superior half of the ear auricle? So innervation of the superior half of this area, this auricle, does not come from the great auricular nerve that we just talked about. Rather, it comes from the lesser occipital nerve. Okay guys, we're almost done. We've provided some images for you to label. Recalling these images in a time setting will help you to perform well on the practical part of your anatomy exam. So label the images and then we'll be finished. Thanks.